if this is the, say, the mother, and this is the father, all right? Each one will have two determinants, okay?
This is normal.
Yes.
These are
Carriers.
These are carriers.
Yes.
So the chances of these carriers still having a child with a sickle cell, like it will be like
if they marry somebody else who is a carrier. A normal red blood cell is round like that. A sickle looks like.
Hello and welcome to my YouTube channel. My name is Ida Munzati. Today we're going to look at sickle cell disease. So on 19th June, the world marks Sickle Cell Awareness Day, and that's why we're bringing you this particular episode just to create awareness about sickle cell so that you're understanding what sickle cell disease is. And if you're a sickle cell warrior, again, we are basically going to look at how you can live positively with sickle cell disease. Once again, my name is Ida Munzati, and joining me is Professor Jessie Githanga, and she's going to help us just dissect what exactly sickle cell is, the diagnosis, issues to do with carriers, and most importantly, how you can live positively with sickle cell disease.
Yes.
All right, and just in a layman's language, I know you're not an artist, but we'll still use the whiteboard. You've talked of like a C-shaped red blood cells and the normal red. Maybe you can just for someone so that they can visualize and get to see.
A normal red blood cell is round like that. It is an area, and if you look it end on, it sort of seems like it has a pale center, all right? That's a normal blood cell. A sickle looks like, is it a quarter moon or like sickle, which is the thing they use for slashing grass? That's where the actual name came out. I'm not an artist, as you can see.
But we have the idea.
Yes, so the ends are pointed and it looks like that, and then it just looks red. So this kind of cell forms that shape. It is sticky, so they clog up in the blood vessels, and they also damage the blood vessels. And that now is where the disease comes on, because they're easily destroyed and they can affect any organ or tissue in the body. So from the brain, the eyes, the chest, the liver, the kidneys, the spleen, the skeletal system, or the legs and the arms, every organ, the skin, everything can be affected by this.
Like the blood is not flowing, the red blood cells are
yes. And remember, they had that important function of carrying oxygen. So if a tissue or an organ lacks sufficient oxygen, it gets damaged. Yes.
I'm also understanding.
And then one of the other things that a parent would notice, beside the hand and feet swelling, the anemia or the lack of energy in this child, is also the eyes. They may turn yellow. That is known as jaundice. And this is because when the blood is destroyed in the body, a byproduct of this red cell destruction is called bilirubin, and that's what causes the yellowness of the eyes. Yes.
Okay. And so let's say for a child, do they grow up? This child has sickle cell. So do they grow up with the same characteristics?
So, as they grow, things like the swelling of the hands and feet will go away. Usually by about 2 to 3 years, it has gone. But then they now start having what we call the other pain crises. Pain in the chest, pain in the limbs, and frequent infections. So they are liable to get frequent infections because the spleen, which usually works well, stops now working very well. And then they can also have, the spleen can enlarge, and when it enlarges, the blood can pool there, and they can lack sufficient blood in the body. And that can be catastrophic in a young child. As they grow on, then their organs start getting affected. They may get what we know as gallstones, that is in the gallbladder of the liver. They get stones, and that time their eyes can become intensely yellow. and the urine can also become very yellow. They may also get ulcers, leg ulcers. These are ulcers usually found in the area of the ankle, and these ulcers don't heal. And even when they don't have infection, they just don't heal. So you see someone with an ulcer and it doesn't heal. Then their organs start getting affected. Their eyesight is affected. Their heart, they may get heart failure. Their kidneys, they may start getting kidney failure or kidney manifestations. One of the most serious side effects is stroke, where they get a stroke and their brain is affected and someone may be paralyzed. And once somebody has a stroke, they're liable to get a second and even a third stroke. So that's an unfortunate thing about that. Yes.
Okay, so I'm just getting to understand, because again, I'm very big on non-communicable diseases. So I'm just understanding that sickle cell is a non-communicable disease. But the fact that you have sickle cell, you might end up having other non-communicable diseases, like you talked of a stroke and even
heart disease, kidney disease. Yes.
Right.
Yes.
And with all this, everything that you mentioned, I know that you talked a little bit about the diagnosis and the treatment. So maybe we can just talk about that now deeply. Then let us look at the management, sickle cell management, and is there treatment for sickle cell?
Yes. So the treatment is, there's unfortunately no single magic bullet. It's not like you can take a pill every day. You try and manage several things. So one of the main things is that it's important to diagnose these children early. Because when they're diagnosed early, then you can start giving them treatment to manage. So some of the things is, because of this frequent hemolysis or breakdown of the red cells, we give them a vitamin known as folic acid that can be deficient in a child with sickle cell anemia. There is a drug known as hydroxyurea. You may come across it as an anti-cancer drug, but in a certain lower dose, it is used in sickle cell anemia because it prevents the sickling of the cells. It helps prevent that. And when it helps prevent that, it helps prevent long-term organ damage. So that is one of the key cornerstone drugs that we also will prescribe. In young children, we will also give penicillin V, or that's an antibiotic, to prevent them getting frequent childhood infections caused by a certain bacteria called pneumococcus, or a bacteria that causes pneumonia. Vaccinations are key. Besides getting their normal, and it is very good that most Kenyans children get the vaccines, because it really helps. It has helped improve the lifespan of children with sickle cell anemia. But there are other vaccinations we may also give them, just to prevent infection, because these children are prone to get infection. And then we will also do tests to try and detect and prevent organ damage. So for example, as you see, I mentioned stroke. There is a test, which is a sort of ultrasound test that is done of the brain and the vessels in the brain to try and detect if there are any changes that can predict that this child is more likely to get a stroke. And then we can start preventing that. Every year from a certain age, we can now look at, from say 6 years, look at the heart function, detect any changes in the heart function, in the kidney function, eye tests. So that's why detecting them early and giving them access to care is very important, and long-term care. Yes.
All right. So with sickle cell is more of a
management.
Okay.
But there is cure. But we say this cautiously, because bone marrow transplant, that means that you get bone marrow from somebody who is AA, normal, and you give that bone marrow to somebody who has sickle cell anemia, after, of course, you have done some sort of conditioning that is removing the sickle cell anemias or suppressing their bone marrow function of producing these abnormal cells. So you give them the bone marrow, cells, or what we harvest special cells, and we give it to a person with sickle cell anemia. And when it goes into the goes into the bone marrow of the sickle cell anemia, it starts producing normal hemoglobin, red cells with normal hemoglobin. However, it's not open to everybody with sickle cell anemia. One, you have to have somebody who matches. It's similar to blood transfusion. If you get blood transfusion from somebody who doesn't have your blood type, that is a disaster. The same with bone marrow transplant. You have to have somebody who matches, okay? What we call haploidentical, meaning they match the sickle cell anemia patient's bone marrow. Again, there are also side effects. During your suppressing the sickle cell anemia patient's bone marrow function, they are liable to get infection. And then there are some long-term side effects. It can be malignancy, it can be cardiac side effects, it can be also brain affect the side effects that can affect the brain from this procedure. Therefore, it is not something that is lightly taken. But where you have somebody who has identical bone marrow, then most people are saying that is a patient who you can, or somebody you can give bone marrow transplant. And lately now we have what is known as gene therapy. That is the latest child on the block. A lot of it is still experimental to see, even if it does work, what are the long-term side effects? Because you may have heard some reports that in some people, acute leukemia was one of the long-term side effects of a certain gene therapy that has been withdrawn from the market.
Right. So with a bone marrow transplant, of course, not every person with sickle cell is a candidate for that.
Yes.
And of course, there are tests that are supposed to be done for that to happen.
Yeah.
And as we wind up, I would like us to talk to sickle cell warriors. But just before that, I know they go through a lot of stigma, a lot of discrimination. But let us just bring it home. What is the prevalence of sickle cell in Kenya, or maybe in Africa, maybe regionally, or even internationally, so that people don't think that we are talking out of the blues, that this is something that is not happening. And in Kenya, do we have regions where the prevalence is a little bit high from others, and why?
Yes, the prevalence varies in Kenya worldwide. However, Africa as a whole has 75% of all the sickle cell patients in the world. So you can see we bear the burden. There are some very high prevalence countries like Nigeria, you have Central Africa, Tanzania has also high prevalence, Uganda as well, Kenya slightly lower. And in Kenya, what you find is that there's a high prevalence in Western Kenya and the coast region. And then places like Nairobi, where there's a lot of migration, tends to be, might be a higher prevalence than in, say, places like Narok. If you go to Narok, or you go to other counties around there, if you go to Northeastern, it's not as high again. All right. So again, the prevalence of sickle cell in Kenya varies. Now, we don't have current work done all over the country. What was done was pretty much a long time ago, where they went testing people for the trait. But we have some current work done in Kisumu County, where they had a neonatal screening program. If one was to do neonatal screening, you'd get very good prevalence. So there they found up to 3% of the children born have sickle cell.
That is in Kisumu alone.
In Kisumu alone, okay? So, and that's one of the high prevalence regions, okay? So again, that is to tell people that yes, it is high. And ideally, you would want to test every child, even in areas where it's not so high prevalence. So if you went to Kiambu or Nyeri or something, because of migration, intermarriage, yes? So all that is causing a difference.
But what I'll want to know, you mentioned over the Western region and the coastal region. Is there a specific thing that makes Western region and the coastal?
All right. Okay. So Western region and coastal region are the high prevalence areas in Kenya. And why, you may ask why? This is because sickle cell anemia and malaria are closely interrelated. It doesn't mean that if you have sickle cell anemia, you're resistant to malaria. But it has been found that those people who have the trait AS, they do not sometimes suffer the severe consequences like cerebral malaria as much as people who do not have the trait. And because of this, evolution is very clever. It sort of tends to preserve the certain traits that give you a survival advantage. And therefore, because of this, the people who had AS tended to survive. But then, you know, when they married someone with AS, then you got SS, and that is the disease. So anyone with sickle cell anemia getting malaria will be very sick, and it's fatal. But somebody with AS may be or may have some resistance to very severe forms of malaria, like the cerebral malaria. Yes.
Right. And now let us talk to a parent or a caregiver to a child with sickle cell, or even someone that has sickle cell, the sickle cell warriors. As I said, I know they go through a lot of stigma, whether it's in the society, at workplaces, in schools. What will be your word, not just to them, but to the society as well?
Yes. So, especially to parents, when your child is unwell, it's important for them to take them to a hospital. Unfortunately, sometimes the awareness of the healthcare workers that a child who's unwell may be having sickle cell is not there. So it is, and we say that it's important for the public to arm themselves with knowledge about sickle cell. How does it present? And I told you some of the early signs that make a child present with sickle cell. When your child has sickle cell, it's important to ensure that your child gets all the vaccinations that will be required. Your child is regularly followed up by a doctor who's aware and knows how to manage sickle cell, because there'll be frequent pain crises. You also know how to manage the pain. When a child says they have pain, sometimes we wait, let's see how bad it gets. No, give the pain medication then and see whether it's getting. Keep them well hydrated. Give them plenty of fluids during the day. Children will play, they'll forget to drink. And when they're dehydrated, that can precipitate a crisis. If they get an infection, take them for care immediately, because that infection can precipitate a crisis like even the acute chest syndrome, which is one of the bad crises I forgot to mention, affects the lungs and looks like pneumonia and can be fatal. So take your child for care. Encourage them, all right? And talk to the teachers so that they know, because sometimes the teacher thinks, this child is lazy, they're not concentrating, they want to get away. When it is cold, keep them warm, because cold can also precipitate a crisis. And, so that, in the community, I urge you not to stigmatize, because there's a lot of stigma from myths. Some of the myths, people think it is cystic sickle cell can be transmitted from by touch, by cough, by sitting close to each other. Or sickle cell is they're drug addicts, because very often they have to take medication, especially even things like morphine for the pain, that people have said, those are drug addicts. Or that they're skivers. Employers sometimes do not understand. And they say, you're going to hospital all the time, or you're always off sick. But they need empathy, they need understanding, because they work very hard. And they're one of the dedicated workers that one can have. So we need to, and destigmatization is by what you're doing, letting people know what sickle cell disease is. Just like we try to destigmatize other communicable diseases. So that, and non-communicable diseases, the same thing needs to be done for sickle cell anemia.
Right, thank you so much. I know that one sounds like a call to action, but you can give us your last word, just a final word.
My final word is that there is hope. Because what you may have heard now may be distressing, it makes you feel, there's no hope. There is hope. There are treatment guidelines that have been published by the government, neonatal screening guidelines. What we need is implementation. I urge all healthcare workers to read those treatment or management guidelines so that they know how to manage patients with sickle cell disease. Because not every hospital will have specialists. It's not a disease that can only be managed or should only be managed by specialists. Every medical officer, every clinical officer should know how to handle the pain crisis, how to prevent, how to monitor a patient with sickle cell disease. And to the government, we'd like to see implementation of these beautiful documents so that we see neonatal screening taking place so that when a child is detected at birth or at the first vaccination that they have sickle cell, they are shuttled to care. And the same thing, access to care. We have the SHA, which is in the plans. Sickle cell is going to be catered for, but we need now that to be harmonized very well so that it is for a patient to pay out of pocket all the time. It's pretty expensive. And to you, the public, please welcome, please hold their hands, and please be empathetic to the patients and the families who have sickle cell disease. Not to say that family there has that disease. Yes, but please embrace them. And there are sickle cell foundations which actually are available for patients and their families who have sickle cell disease.
All right, thank you so much, Prof. Thank you for the knowledge, for the information, and basically for just creating an awareness and for your time, most importantly. All right, that was Professor Jessie Githanga. We've been able to understand what exactly sickle cell is. We were basically just joining the world in terms of creating awareness about the sickle cell disease. So we've looked at what exactly sickle cell is. We've looked at the diagnosis, the screening, treatment, as well as the management. And as Professor Jessie has said, if you're a sickle cell warrior or a caregiver to a child with a sickle cell, there is hope. Thank you so much for tuning in. I hope you've been able to learn and understand. My name is Aida Munzatsi. See you on the next episode. As I always say, your health matters.